I'm going to quote you here. If you could give one brutally honest piece of advice to a physician just stepping into a leadership role, what would it be besides quote, buy stock in whoever's screwing over your patients, unquote?
I couldn't have said that. That was
yeah, you could have.
I could have. You're right. Yeah. So don't second guess yourself and just do things. You should just start doing things. If you don't understand, ask the question. But I would just say step in with confidence because you belong there and just do things, unapologetically and without fear.
Yeah. Again, echoing, use your voice, use it the right way. Hello and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast brings you the hottest and most crucial conversations in healthcare and physician leadership today. On this show, we have recently talked a lot about how decisions get made relative to our professional obligations as physicians against the needs of a role, whether you're in a hospital role, whether you're in Congress, in the Veterans Administration, as Surgeon General, or even in service to the President of the United States. And as a leader, you do not always have all of the information available when you are required to make a decision, the kind that only you can make. One of the most frequent questions that I receive is about how should physician leaders stay current with today's healthcare in order to have enough information or simply awareness to make the best possible decision. Today's guest, Preston Alexander, the self-proclaimed Taylor Swift of healthcare writing, with over 30,000 followers on LinkedIn, publishes a weekly newsletter, The Healthcare Breakdown, in which readers get Preston's breakdown ranging from hospitals to digital health startups and relates to finances and strategies and overall business models in healthcare. Having managed millions of dollars in the medical device industry and growing and selling healthcare business ventures, Preston is now involved in Forward/Health, a company on a mission to enable physicians to open, run, and grow private practices. Preston, welcome to the show.
Thanks so much for having me. It's wonderful to be here.
You told me and you described, and you've said it publicly, you did not start writing about healthcare with the intention to create a newsletter, but rather to share your thoughts on the macroeconomics of U.S. healthcare, to learn and to absorb as much as possible through the act of writing. And right now, you are about to step into the world of launching independent physician practices. So we'll talk about that venture shortly, but let's start with a basic principle. You have an MBA, right?
That's right. Yep.
And we talked a little bit, physicians spend many years becoming competent clinicians and often do not have an MBA. And they reach a point in their career when they simply want to focus all of their energy on caring for patients. And as you are going to support your physician clients to establish their own practices, do you see gaps in their healthcare financial acumen?
I definitely see some gaps, but I will say that I don't think they're necessarily problematic. And what I mean by that is that while there is sort of an academic element to it, if I start talking about EBITDA, someone might not know what that means. If I start talking about, debt service coverage ratios, you might not know the calculation, those sorts of things. However, there is certainly the aptitude to know what those things are. Oftentimes it just takes a labeling or a definition. And then it's like, oh yeah, I understand that. And you probably already thought that way. You just didn't have the words that someone with an MBA or someone with a finance degree used. And oftentimes when we see physicians stepping into their new practice, or if they're getting advice from certain people like, oh, you should get your business degree, or you should get an MBA, or you don't know this, or you don't know that, it's really easy to say, oh, I don't know, because they're not saying all of the things that, they're not defining it. They're not saying, here's what you don't know, and that's going to be hugely problematic. They're just saying, you don't get it. But they're not really telling them what they don't get. And oftentimes you get in there, you get into a practice, you start billing, you start paying for overhead, you hire someone, and it's like, oh, well, yeah, I need to make this much money this month because I owe this much in bill. Like, it's not as complicated. So the aptitude's there. Often it's just a missing definition set. And once that's sort of the curtain is pulled back, I find that most people, I mean, listen, physicians are way smarter than I am. So they can get it, and they do get it a lot of the time. So while, yeah, there can be a gap, I don't find it to be hugely problematic.
Yeah, I think, and my wife will attest to this in a court of law, that physicians are the smartest dumb people she knows, me included. We do have an aptitude, and we are smart about some things, but we can be ridiculously dumb about some of the most commonsensical things, even running a practice. And yes, we may not know the nomenclature, and we do the same thing to non-physicians. We speak in terms and use language and describe diseases and organ systems, and people don't understand what we mean. But if we explain it to them, most everybody really does understand what we're talking about. So it's sort of this shared awareness. You, Preston, you know things that I don't. You have names for things that I don't use, and vice versa. And it feels like some of your writing and your efforts have been to try to level that playing field. Does that seem accurate?
Yeah, that's definitely accurate. I mean, my goal with the healthcare breakdown, with posting on LinkedIn, and recently with the /health newsletter, which is a new newsletter that's a little more hyper focused, is to just break down some of those things that people say are too complicated or too obscure, or you're not uniquely qualified to do, and say they're not as complicated as they want you to believe. In a lot of circumstances, you can understand it, and just showing here's what's going on, because you can explain it in plain language. And once you get it, or once you read it once or see it a couple times, then I think it changes a lot. And it certainly changes the narrative too, that we tell ourselves and that others tell.
Absolutely. I endeavored to write a book for chief medical officers to help bring them some common narrative in a story format about the finances of healthcare systems. Many of our physician colleagues today never were paid a true fee for service in the office. That sort of died out in the late 80s and early 90s as the RVU models came into being and different billing and collection systems came online with the advent of computers. And so they don't really understand the original flow of money. But to your point, once you lay it out, it's pretty straightforward. And you can call it an RVU, or you can call it a fee, or you can call it this, or you call it that. But I do something. And as others have said, the money people just pay you, but there's a whole world around that. And not knowing that world is a power dynamic that many people have enjoyed using over physicians for years. And everyone knows now that just about 70% of physicians are in some type of employment model in healthcare today. And that is a striking number compared to about 20 or 25 years ago.
Mhm.
So yeah, I don't want my fellow colleagues in chief medical officer roles to run out and get an MBA unless they want to, and they have a certain game plan, because nobody wants to talk to you about LIBOR. And I don't care if you say EBITDA with a straight face or you don't. But I do want you not to be subjected to that power dynamic that occurs in an executive room. Does that ring true with you as well?
Yeah, I mean, I talk to people all the time, all sorts of clinicians, and they always like, I'm thinking, they always say, I'm thinking about getting my MBA. And my question is always why. Like, I know why I got my MBA, and I really enjoyed it. The coursework was interesting and fun. But at the same time, the example that I like to give is that I came out of my MBA, went to be a product manager at a global med device company. And if I had written an email to my CFO the way that my communications professor had suggested that I write an email to them, they just would have deleted it or never read it, because we're talking, bullet points, a couple sentences, the way that we are taught project management or operations management. Like, yeah, principally, that's the way it should be done in an idealistic environment. But when you get in there on a factory floor, when you're in the office working in a sort of silo, and then you have um, colleagues geographically dispersed literally all over the world, like, how do you pull those people together and actually communicate and get them on the right path to be moving forward in lockstep and really organize? Like, I can't put up poster boards all over the room and do this sort of ideal approach. So yeah, you can learn some great principles in business school. It can be fun. If you're going for the sake of learning, I think it's great. If you're going to some business schools for the sake of network, and you can afford it, I think it's great. But if you're going because like they tell you you should, or you feel like you don't belong in the room because everyone else did it, I don't think those are necessarily the right reasons, because you'll find, oh, I could have figured that out on my own. I knew that already. Like you'll see a lot of those things come up, like, oh, we do that, right? Like they're just giving like definition to what you already know.
Yeah, yeah, I would echo that. I think there has to be a degree of intentionality about the MBA with a real, you have to war game it in your mind a little bit. I want to be the leader of the largest health plan in the state of California. Yeah, it probably would be a good idea to have a reputable MBA to say that's your goal. If you just want to get in the C-suite of a community hospital of 250 beds, you can walk the walk and talk the talk without necessarily carrying those credentials. That's what I think. And it sounds like you would agree.
Absolutely. I definitely
Yeah.
agree.
All right. So we've laid the groundwork there a little bit about business acumen and skill sets. Here's an interesting question. Do you think physicians in leadership, and I was a chief medical officer, and I know many who have been in this role, are complicit in the financialization of healthcare today? Or have they been so outmatched and outmaneuvered, like we're discussing, by leaders who have these prestigious MBAs who have bought and sold businesses while the physician's busy taking care of the patient? Do you think that we as a community, and it's okay if you have a very raw opinion of this, that we are ourselves complicit in that financialization?
I think that's that's a pretty loaded question. But I do appreciate you asking it. And I suppose if I could be so bold, my opinion on the matter is maybe a bit of a different type of answer, where I don't know that, being complicit or not is necessarily the right answer. I think it's more of a, well, what are the systemic mechanisms and what is the system in place that has led us here in general? There's obviously an altruistic element to providing healthcare and just caring for people who are in need. Um, but at the same time, we've taken these entities and we've given them tax breaks and all these different things. But we've also said to them, it is also up to you to survive financially by battling with five of the largest companies in the world that control trillions of dollars a year, that are publicly traded, privately owned. We're going to let you go to war with those companies to make enough money to survive, to provide the public altruistic good that you were designed to provide in the first place. And we have told a 250 bed community hospital to go fight those companies, the most powerful ones in the country and the world, to get to scrape what they're owed for the services that they provide as a public good. So those are the mechanisms we have to operate in. And I think it's really challenging, though, in that environment and maybe impossible to an extent, to stand up and say, like, we can't think this way in terms of finance. We have to design it this way for optimal care, for optimal things. And I do believe a lot of that is critical and the business stems from it. But it's easy to see why it's the other way around, given those constraints and given that system level, that you have to say, well, we have to stay open. We need to maximize our revenue. Our costs are going up. People are harder to come by. Banks' interest rates are up. Our debt service just got more expensive. We have a big health system coming in. If we want to survive, we have to buy practice. Like all of these things make a lot of sense when you just look at it from that macro system perspective, in my opinion.
No, well, I wouldn't have asked you if I didn't want to hear your opinion, and I like the opinion, and I'm going to build on it because it was a loaded question, and the framing of it sets up a person, not intentionally to you, because the physicians were caught up in the systemic structural design relative to third party payment. And in my book, what I try to explain to young physicians is there was a time where when you went to the hospital because the trolley ran over your leg in the street, they charged you a nickel for the gauze and a penny for the coffee in the morning, and it was like cost based charges of like it cost us a half a penny to make the cup of coffee. We're going to charge you a penny, and there was no third party involved. And if you didn't have any money, well, you went on a plan to pay back the hospital and the doctors, and it was an old bartering system. It was an old mercantile system. It had nothing to do with the way the system is today. And once third party payment structures became a vehicle for the flow of the money is when it kind of got off the rails a little bit, and slowly, bit by bit, like the water drips and builds the canyon, that's where we are. And so I think fundamentally, I believe you and I are probably in agreement about it isn't that the physicians were complicit, but they were caught in this evolution of change. And at some point, it got away from individual doctors and individual agency. And there are many of independent docs, and people are doing quite well in some areas and not. And some are serving the public and some are serving themselves and their communities. And it's okay. That's the way we as our country has evolved. Okay. So thank you for the answer. Didn't mean to make you feel on the spot.
No, it's great. It's a great question.
So keeping these thoughts alive. Our listeners are physician leaders, and they're involved in some of the decisions that get made day in and day out, the metrics of a hospital, the KPIs, the movement of these dollars. And we can talk about small clinics, we can talk about ASCs, we can talk about hospitals, but where the margins are so thin. So let's ignore the folks that are seeing hundreds of billions of dollars and put those companies over to the side. We're talking about the actual deliverers of the care, and their margins are relatively thin. Outside of, say, the top 10 HCAs and Ascensions, everybody else is razor thin. Even at the last Kaufman Hall that I saw just the other day, still razor thin. What should physician leaders be doing to influence the decisions that get focused on metrics and margins as opposed to care delivery? How do you think they should be wrestling with those almost conflicting principles?
Yeah, that's a great question. One, I don't know that they are necessarily as conflicting. I think that taking that systems based approach, they don't have to be in conflict. To me, financial performance is often a lagging metric. You financially perform well because you took care of patients. And sure, there are, again, always going to be dynamics. The payer mix, or is it heavily Medicaid or uninsured population, things of that nature. What are the cost structures of the hospital? You have to stay open, you have an ED, et cetera. But if you look at it all kind of like, at a systems level and say, okay, well, we're on this razor thin margin, asking questions, well, why? What's driving it? And they say, well, our overhead's really high. Great. Everyone's is. Where specifically is it incredibly high? They're like, well, everywhere. Okay. That's always true for everybody too. But then maybe disproportionate to the revenue that we generate in the hospital, where is it too high? And they'll say, well, the ED, or well, labor and delivery, or whatever else. You say, great, that's fine. Thank you very much for the information. Let's go see why. And as you go down into these like smaller and smaller components, you can really start to see maybe what processes don't work well, what leads to waste, what leads to people doing too much work that they don't have to do. And it can be really crazy simple things. It can be the fact that, the nurses on the floor can never find the 7 things that they need the most often. And so, okay, well, let's take a system-based approach and put the mechanisms in place, because now you're improving efficiency, but you're also not running up against expiry dates on products that you have to buy more of. So it all sort of starts to be really interconnected and really interrelated, and allows you more time, often more investable dollars to give back to the patients. Maybe you can hire more people. Maybe you can, buy the equipment that you've wanted to buy for however long. So I think it's really important to sort of like break things down to the sort of lowest common system within, and then take that system's viewpoint and figure out what's actually broken within it. And it's a similar principle to what you would think of as like, cost-based accounting or activity-based accounting, which is crazy hard to do, which is why nobody does it, which is also why if you talk to most financial leaders in the health system, they can tell you their department costs, they can tell you the hospital costs, obviously. But if you say, no, I want to know how much it costs for an appendectomy on a Thursday afternoon when Dr. Scheinbart is doing the procedure. And they're like, what? But
yeah, they're going to say what, because I haven't operated in like 40 years. So
maybe,
that's a non-starter.
But so, it's getting down and breaking down to those levels. And then you can start to say, well, look, when we did it like this, we had these better outcomes. We had these more satisfied patients. And by the way, our staff was happier and we reduced this much cost because we created a system that worked better.
Yeah, you stole one of my greatest questions in my class where we teach chief medical officers. Go down the hall to your CFO, knock on the door, and say, "So, how much was that hip replacement? Like, what did that really cost?" They don't have a clue.
Yeah.
They cannot give you that answer. They don't want to give you that answer. So, kudos to you for knowing one of the coolest questions in medicine. So, what does an event cost? Right? Not how much did the prosthetic device cost, but the entire event, start to finish. Love that question. I think you framed it very nicely, and it's an argument that I've used in terms of shaping healthcare. There's a fabulous chief medical officer at Scripps out in San Diego who also has the chief operating officer role. And in talking to her, it's lights out because she has the ability to do a lot with a lot of authority and responsibility. Exactly what you said. Go down to the ED, look for the equipment, look for the X, Y, and Z elements that are blocking the flow of the care of the patient, that are inefficient and wasteful. And because she was an emergency room doctor, she gets it instantly, and she knows the frustrations of all the players. And I have another colleague of mine who was both CMO and later COO of an entire system. And so I make the argument that there ought to be some equivalencies of physician leaders in roles that can see things because they did it themselves, that would help reduce the waste and the inefficiency. Now, I've also been in an inner city hospital inside of New York City, and I'm not sure that, to your point about payer mix and demographics, that is a public safety issue that requires public support. That I don't care how smart and capable some of the leaders are, that there's just not enough revenue, no matter how awesome they are. Does that make sense?
Yeah, absolutely.
Yeah. So, in some organizations, and we'll go back to the power dynamic a little bit, healthcare executives unfortunately still treat some physician leaders as like the worker bee to solve the doctoring things, behavior, documentation, quality, and in the worst case, sort of a window dressing, and that all the real decisions get made in the C-suite of the boardroom, regardless of the physician perspective, even if they have an MBA from one of the greatest institutions on the planet. What might happen in your mind, and even if it's not totally true, but directionally, sort of change that dynamic at all?
What needs to happen to change the dynamic?
Yeah, relative to decision making, right? So if my premise has some level of accuracy, that there are non-physician executives running healthcare systems that are dismissive of the physician leader, in other words, they are window dressing. How do we alter that? Could we alter that? What do you think about that? And you want to drive independent practices, but I'm asking you from an organizational perspective.
Yeah. I mean, short of everyone walking out and saying we're going to go start our own thing, obviously, which isn't actually that helpful of an idea, because we need hospitals. Don't get me wrong. Never been on the let's have no hospitals bandwagon. Should we be able to have more physician-owned hospitals again? Yes, but a different topic for a different time. I really think the answer maybe lies in kind of the nature of the business, or any business, which is that the results are the thing that matter the most. And, there's always going to be organizations where at the very top, there's just, it's a brick wall and they're going to think a certain way, et cetera, et cetera. but they do speak in terms of the financial health of an organization. And I mean, yeah, they do. I think if you get on a personal level with folks, they care about people and they care about patients and they want to see those great things. They also care about the business results, and the business results are going to speak for themselves. So I think that to change the dynamics, that you don't ask for permission, just go do something and go out there and lead from wherever you can with whatever you have from wherever you are. And there's always going to be politics and dynamics. Again, obviously understand all that. But I think that the results and in any organization are going to be the most important lever that you have. Influence is important, having the right people, all that stuff. But if you can walk in, if you can go to a board meeting, if you can get an audience with other executives, if you stand up and say, hey, while y'all were golfing the last 2 weeks, here's a project that we initiated, and show the business case and show the results and show the numbers across the board, I think those are the things that start to really shift and let people kind of sit up a little bit, because it doesn't always come up as much. I think even in higher executive level situations, it's really easy to fall into like, here's my role, here's my lane, here's what I do, here's what they do. And then, yeah, the machine just keeps on turning. But don't ask for permission to do it, just go do it. And then go let the results speak the volumes that you're trying to influence from that perspective.
Extremely insightful. Couple of things I want to react to, and we'll take your reaction and my reaction. So, physicians generically, while we have aptitude and we can learn, our motivations are often very different than C-suite. And I get it, and it took me a long time to understand it. They are driven by different, the currency of their motivation, what drives them is very different. And that's fine. I mean, that's just human nature. And there was the time, you remember hearing everybody should have a dyad model, right? A dyad model. And there's value to that, but the dyad has to be able to be functional and not dysfunctional, and not hypermatrix and all these different organizational ideas. But a dyad model where the physician is the clinical conscience of the organization and the CEO is the business conscience, and they have to be married and they have to work together, and one can't superimpose on the other unless it's a threat to health and safety, right? That part's a non-starter. Now, to the question about physicians getting MBAs, right? Sometimes they're told to go get it and check the box, but it's not in their internal motivation to be the business king, right? They don't get jazzed. Some do. We'll come back to that by running the business. They just want to provide healthcare and patient outcomes. And so it is. So to answer the question in this theoretical black box that we're talking about, is let's have physicians who either can find the right dyad partner. They don't need to circumvent. I do think they should get stuff done, like you said, and they don't need permission. But not everybody knows how to do that and wants to do that. And so boards and C-suites can structure their teamness around this type of thinking. And they did this in the design world, and you may know something about this, about the plumber and the dentist and the cabinet maker and the janitor all come in the room and they have to solve some problem. And everybody comes with this wildly different perspective, and they come up with this device that no one's ever heard of. Does any of this resonate as a theoretical approach, but could be applied in real life?
Yeah, I mean, I think so. I think based on the sort of theory of the dyad or these different perspectives. So I'll tell a bit of a story. So one of my favorite roles when working in the real world, I was a product manager. And product management is a super interesting role because whether you're in tech or you're in devices, you're effectively a general manager of a product, which you can think of as its own business unit in a way. What's interesting is you have no functional authority over anyone. You you're not, R&D doesn't report to you, finance doesn't report to you, sales doesn't report to you. No one reports to you, but you have to get them on board with your product. You have to get share of sales team's time. You have to get finance aligned with your vision, what you believe is the price point, what you think the margin needs to be. And you have to bring together all of these disparate stakeholders so that they come together to create something that doesn't exist in the world and then sell it to people and commercialize it. As a product manager, you don't get to say, do this or else. You have to influence how it's done, and you have to bring them together and uniquely leverage their unique insights, skills, etc., for the story, for the thing you're driving forward. It can be the same in your, the metaphor, I guess, of, plumber and electrician, et cetera, all getting together is very similar, because if you can look in the organization, if you're a physician, you're a CMO, you're sitting in the organization, there's all these different departments. There are different, medical departments, obviously. There's all the back office, finance, operations, even if you within finance, the billing, the enrollment, the credential, all these teams, and they all like do one thing great. They'll have very unique perspectives on how the whole works together. So if you can say, well, I want to do this, I think this should be what we do. And maybe it is from a clinical perspective, because like I said before, the finance stuff is a lagging metric. You know, galvanize a disparate team of people together and say, hey, I got this project we're working on. We need to solve this problem. What do you think? What is your opinion about it? How does this impact your daily life? And then start to bring it all together. And those are the things, again, and I know that sometimes it can be in an undefined area hard, I think, for physicians, if I may be so bold to suggest that, for things that you haven't done before, that they haven't done before, to just start, like in entrepreneurship and startups, we're like, just start, right? Figure it out. Build the plane while you're flying it. Da, da, da. But in medicine, that's like a terrible idea, because, people's lives are at stake. But in a situation where you're sort of at steady state, you're not doing anything crazy. We're not talking about injecting unknown drugs into people. We're not talking about implanting devices that have never been tested, et cetera. We're talking about bringing together people to get some unique ideas and perspective on how to solve an interesting problem that could really unlock some improved patient outcomes, improved patient care, better experience for clinicians, better experiencing for patients, and bringing that group of people together. You just need to put yourself in the middle and then kind of galvanize everyone to the same problem solving.
Yeah, great outlook, great metaphor. Sort of finding the noble cause that everybody. What's your rally cry? What's our purpose here? How are we going to do this? This is the problem we are going to solve. Love it. I think that's very helpful. All right, so I try to keep up with a variety of information. I'm at a point in my career where I have a little bit more time and try to see what's happening in healthcare at a macro level to advise and teach aspiring leaders what should be on their radar as they approach that C-suite. How do you keep up and determine what goes into your newsletter, whatever you're calling it these days? How do you do that?
Whichever one it is that needs to be. To be honest, I think it depends. Like if we're talking about the healthcare breakdown, it's a little bit of what is interesting to me at the time and a little bit of what's novel to me. Because, like you mentioned before, the reason I started writing about healthcare wasn't because I thought I knew anything at all. It was, in fact, the complete opposite. I knew that I didn't know much about healthcare. And so I wrote as a means to learn, but also to get feedback to learn even more. So whenever oftentimes actually, when I'm writing the healthcare breakdown, it's a topic that I want to learn more about and become more well-versed and deeper into. I think more and more today, we're seeing news stories and I'll call them famous startups like, Mark Cuban, Cost Plus Drugs, and all the different ones that are coming out are making people sort of more aware, of what's going on in healthcare, and they're asking questions, and they want to understand sort of, Mark Cuban's talking about PBMs, but like, what does that even mean? And I mean, it's a confusing and convoluted industry sort of within broader healthcare. I want to speak intelligently about it, and I think other people want to understand it. So I go research and go deep into it and talk to people and understand it and try to translate it into a simpler format for digestion. So the healthcare breakdown, honestly, is a little bit of it depends. And we did a ERISA piece recently, so there's some trends, and we're seeing these lawsuits come out, about breach of fiduciary duty, and all of the insurers now are embattled. Although United takes the cake for sure. So there's a lot of content there, and it straddles the business of healthcare and what's happening today. And then, the /health newsletter is a little more hyper focused on independence and private practice.
You will be proud of me. I don't have an MBA, but I know what a PBM and I know about the ERISA stuff and the legal issues, because I find that extremely fascinating. And we get into politics and lobbying and big dollars of business. But that makes sense. If I heard you right, you're looking to solve and understand something for yourself, and then once you've done that writing, you share it, which makes it a lot easier than filtering every feed from every you can't do it all the time. Okay, I'm going to hit you with some rapid fire questions because we're getting close to the end, and I want to give you a chance to talk a little bit more about / so your healthcare breakdown newsletter, because I haven't read the new newsletter, doesn't hold back about calling out the profiteering in healthcare. And if physician leaders, as I've framed them, are supposed to be the conscience of a system and an organization, does your newsletter, the Healthcare Breakdown, help them fulfill that responsibility to call out profiteering?
I think it does or can in certain situations, because making a profit isn't a bad thing. I don't think profiteering is a totally different thing. Value extraction and extractive behavior is a totally different thing. At the expense of, is problematic. So yeah, I think unveiling and just peeling back the curtains on certain things and some of the double speak that happens, especially at large health systems, and what's actually going on, can be helpful to say, because you step up and you say, clinically speaking, or for our patients, we should be doing this. And then they say, well, what do you know? Because blah, blah, blah. And you're like, well, sir, actually, here's your balance sheet and here's all the things, and tell me about these investments over here. And it says you lost all this money, but really it was investment losses. And why are we investing in hedge funds? And what about these offshore accounts? And they're like, right. So it can serve as a great way to pull out some of those things, to push back when they say, oh, we can't do it that way because of this money problem or that constraint here. Sometimes those are true, for sure, but they're not always as they appear completely.
Yeah. No, I obviously I'm smiling for those of you who are watching YouTube and those who aren't. I'm smiling because I think physicians still have a very powerful voice, and your newsletter can at least inform them on a subject that they don't know anything about. And if that helps them grow in their knowledge base to push back, I think our voices, we may not be culpable in how the system got structured, but we can speak up about the system and right the ship wherever in our local communities we can. So thank you for that. I'm going to quote you here, and I don't remember if it was a LinkedIn or in the newsletter or you said it to me verbally, but if you could give one brutally honest piece of advice to a physician just stepping into a leadership role, what would it be besides quote, buy stock in whoever's screwing over your patients, unquote?
I couldn't have said that. That was
yeah, you could have.
I could have. You're right. Right. Yeah. So what would be my piece of advice for someone stepping into that role?
Yeah.
I would say, and it's maybe this is trite advice and maybe it's hard advice to give, but again, going a little bit back, I would say don't second guess yourself and just do things, because I think that you should just start doing things. If you don't understand, ask the question. If you think it's ridiculous, say it's ridiculous and why. Like, always substantiate. But I would just say step in with confidence because you belong there, and just do things, unapologetically and without fear.
Yeah. Yeah. Again, echoing, use your voice, use it in the right way. We instruct our students to develop a high question to statement ratio. Ask more questions than making blanket statements. Just ask the questions and try to do it respectfully, but clearly and appropriately. The other quote I wanted to share, even if you don't remember saying it, is you mentioned to me, and I think this was on our verbal conversation, that in order for physician leaders to grow in their role and balance things, they should not be the moral fig leaf for whatever the CFO or CEO decides to do next quarter. Physicians should be part of the strategic plans, the capital allocations, and have some ownership and responsibility of what's going on. In other words, if you're going to ask a question or say something is ridiculous, get involved, bring a solution, go do something, and then not just be that person at the podium trying to explain it away, but just say, yeah, we own this. We did this. We did this. Here's the reasoning. Do you remember saying that to me at all?
I do remember saying that to you.
Okay.
That one, yeah. But I mean, yeah, definitely be a part of it. And again, if you think about, capital allocations of the health system, I mean, it's the CEO and CFO's job. Like they should be saying, okay, where's the best use of our money? But this is a health system. This is healthcare. So if the physician isn't there, the CMO or the leadership of physicians is not at the table saying, you want to allocate fund, like we need to be at the table because you're going to allocate it to 7 new robots so you can put it on a billboard somewhere and tell people you have like robotic, appendect. And it's like, okay, like are rates bad? Did Intuitive oversell you on like the outcomes that we're going to get? Like, why are we doing this? Because there's any capital allocation in the healthcare system needs to be for the health and well-being of the patients. And if you do that right, like we talked about before with systems approach, et cetera, the financial elements are the lagging that they should be able to follow. So yeah, don't just, like fig leaf seal of approval because the CFO made this decision, but help to drive and make the cases for why they're doing it and make sure they're doing it right.
Yeah, it's some really cool stuff there packed in there. Very, very good. Okay, all right. In the last few minutes here, tell us what's happening with /health. Tell our listeners what's going on.
Yeah, well, I appreciate the airwaves to share a little bit more. So, as I mentioned, in a post recently, /health really came about because of a line that I don't know. It just sort of came out when I was writing a post one day that was that the business of healthcare is destroying the practice of medicine. And it's time for clinicians to take back the business of healthcare. And that can happen in a lot of different ways. Obviously, we're talking about physician leadership within organizations, whether it be in a CMO role or in non-clinical leadership, whether that's a CEO or a COO or something. You always bring that clinical element with you, but you don't have to be like the top doctor, the top nurse, et cetera, et cetera. You can be in a non-clinical, quote unquote, leadership position, and then think of the influence and decision making then from a clinical perspective. So that was one, and then two was startups. I come from a startup background, so getting frustrated looking at all these digital health startups being like, what, X Google and X whatever, and they're just doing nothing useful except for how much money can we make, patient acquisition costs, all this stuff. So more physicians actually doing the right things from a physician-led startup standpoint. And the third one being the idea of independent practice coming back to life, because again, I'm not trying to throw too much shade at large health systems or different things. I think it's a system that we need, and it is a system situation that we are in now. But in a lot of cases, physicians find themselves beholden to, you can't refer outside of the network. You have to hit this RVU target, and then reimbursement's the same way. I talk to general surgeons, and they're like, why do I get paid less for a harder surgery with faster recovery time than an easier surgery with worse recovery times? I get paid more. These things don't make any sense. And so there are those mechanisms where then the surgeon can decide, like, I can do whatever I don't have a quota to hit this month. I'm just going to take care of my patients the best way that I can. And that really ended up being the focus of /health. So we're like, how do we help physicians? We started off kind of as a broad consultancy and then narrowed down, and we had people coming to us and said, I want to be independent. I have no idea where to start. And we said, well, we just so happen to know where to start and how to build a practice. We've built practices. We've been in, my partner been in healthcare leadership. We can help. And so we started launching practices. And then we saw, the thing that comes up often and is, RCM and medical billing, because how's the money coming into the practice? How do we create a finance? And that's the lag that I'm, talking about here is like, but somebody has to be there fighting with the mega companies to get the reimbursement that you're already owed. And yes, is documentation a headache? Yes. Like finding and making sure that one of the 100,000 or however many ICD-10 codes there are today is the right one for the right appendage and is a pain, right? But we want to take that off the plate and make sure that you're getting paid so you can, not to just say, leave this to us, you focus on that, but to help fuel that engine so that you're already doing the work. Let us make sure that you're getting what you deserve for the work you're doing. And then you can go open another clinic. You can go hire more people. You can build the practice up so that you can serve more people. So those are the two areas that we found that we could be the most impactful and help for private practice to thrive. Because on the flip side of that too, the reasons why people sell their practice when they may not want to is because it's not financially where they need it to be. And we don't want that calculus to ever come into a doctor's mind. If you want to be in private practice, we want to help enable you being in private practice.
And for clarity, and we've talked about it. You're not an MSO.
Right. Not an MSO.
You're not a capital partner.
Correct.
But that nuts and bolts of RCM and sort of that business back office functions to maximize the revenue and offload and diminish that frontline work that gets in the way of the patient care, right?
Right. That's right.
Okay. And how do folks get in touch with you guys?
Well, I am always on the LinkedIn, so you can always find me there, or /health.com. Drop us a line. You can set up a call, or, feel free to email me directly. It's just Preston at /health.com. Always happy to have a conversation.
Excellent. Well, this has been a lot of fun. It's an amazing amount of material. I love the real world perspective. I feel like we're back on MTV back in the 80s. But most of our listeners probably don't understand that. Anyway, it's been great having you. Any last word before I wrap it up?
Again, thank you so much for having me. And to any physician or anyone else, listening in, you belong in the room. You absolutely, deserve to be there and have huge potential to make the right kind of impact on the healthcare system and on patient care.
Thank you for that. You join our club of strong physician advocates. We have a handful of some strong players in physician advocacy. You have just joined that club. Didn't know it existed, but you're in it now.
Happy to be part of it.
Well, everyone, you've been listening to the Fire Chief Podcast, the only podcast dedicated to the chief medical officer and physician leadership. If you want access to the hottest items on physician leadership, especially if you want to become a chief medical officer, visit our new website, thefirechiefcmo.com, and sign up with us. Leave your comments about the show. Tell us what the next hot mess in healthcare is about and what physician leaders should be doing about it. I love talking with physician leaders and chief medical officers and business leaders in the world of healthcare from all over the United States. So feel free to connect, leave your reviews and your comments, and share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.